That's okay. And what's the other? Tension, right? Contradiction. ये भी चाहिए, and those two things seem in conflict with each other or anything. So you're free. So you take 30 seconds, very short time to write what's on your mind on the post-it. I know you've written it on your thing, but what is the one thing that stands out to you? Either a contradiction or a quote or a theme. Theme I'm not saying because I've become very gentle. Quote or a contradiction, or if there is anything else that came to your mind which really was different, which you hadn't thought of before. Okay, so just 30 seconds. And if you're writing two different things, then please use two post-its. If you're short on post-its, please let us know. Raise your hand. Okay. Now we are going to get up. We're going to do the same thing pair share. And in the first round, you will find one person to talk to with whom you haven't talked to in the 2 days. And you will talk to each other. And then in the second round, you'll be pairs will come together. So you'll be 4 of you, right? Okay. And you have to follow my instructions. You don't have to do what you feel like doing. Okay? So, alright, get up, start walking. You can roll your shoulders, you can swing your hand. Yeah, it's going to be a slow walk. It's the afternoon. The faster you walk, the more cake you get. Okay, let's get up, let's stand up, and everybody is included in this, including our organizers. No sitting, let's get up. Stand, some people are sitting, I'm watching you, I have my eye on you. Let's 5 people you don't walk with directly every day. 2 people, not 4 people. A code, attention. That really stood out. No permissions needed. So now what we are going to do is 2 of you stay together and join another 2. Don't change your pairs, join another pair. 5 minutes. So now make groups of 4. Merge. Also phone. All right, now we're going to come back. We're going to come back to our places. We're going to come sit. Come to your places. Thank you. Okay. I'll hand it over to Dr. Priya.
Hi. Can we all reconvene, please? We are so caught up in our, sharing. Can you reconvene? Please come back to the other group, please. Before we transition to the next session, we would like to conclude this session, which is that great work, all of you, because we found that all of us were taking note of the entire panel discussion, which is great. But then we are also taking forward, right? Say have you Thank you. So what we will do now is these downloads, whatever we have done. All of us, some of us have handwritten notes, some of us have a Word document typing, some of us have directly built into the rubric. Whatever form it is, those who have actually handwritten down and made a Word document, please read through and fill in the rubric. Whatever has been there in the workbook. And please download it, fill in the download it, fill in the rubric, and keep it for tomorrow. Yes? Is that making sense? How many of us have a Word document of what went on there? Kind of ranking. Yes, could be handwritten or Word document. So, as it typed in. So, please read it and use that to identify the themes and thoughts and designated barriers, tensions, contradictions, and fill in the rubric which is coming after that, the panel recording is the data. So that much we will do tonight, and tomorrow we will have a debrief morning. So that each group that we are sitting now, okay, we have many more groups. The 3 original groups, we will convene tomorrow at the 3 original groups, and then we will reach a consensus on the panel, the pointers that we have, right? the civil, these are very, so ideally the, I mean, whatever the brain is a civil framework, the frame, right? That's how we are going to do the framework analysis. And that's going to lead us to the next session in terms of what to do about it. This is fine? Yes, thank you very much. Thank you for your engagement. Yeah, any questions, you can always reach out to any of us. Thank you. Yeah. Okay.
I welcome Dr. Premoni. He is one of the well-known researchers in the field of epidemiology. He works with the St. John's Research Institute, and he has been conducting implementation science workshops for several years in this hospital. And I think two of my postgraduates, two of my team members you have attended, right? Parvati and Anne. I think two of them have attended your workshop and they're very happy about it. So today we have Dr. Prem to tell us about the outcomes of implementation study. And so let's hear from him and we'll engage with him post presentation. Thank you, Dr. Prem.
Not from the ICU or palliative care background. I'm from primary care, normally in government, some clinic in Bangalore, but also dabbled in implementation science where only government to improve care for known interventions. And I will try and cover two subtopics: implementation outcomes and the study phases for a project that you are all undertaking. So under implementation outcomes, I'll try and quickly finish off what a research pipeline will look like and where does implementation research fit in, and then move on to details about the implementation outcomes. Thanks to Dr. Stallings for already covering this bit. Typically, ICMR uses these words: descriptive research, to try and get across what are the problems from the patient viewpoint or the healthcare provider viewpoint. That's the starting point. We normally describe the current situation. And then moving on to the next phase where somebody makes a discovery. It can be a drug or it can be a treatment regimen, which we then want to try out first before we go to the rooftop and say this is the best treatment. So the second part is the discovery science. For palliative care, it's probably a combination of some molecules or drugs that you want to use, but also new bundles of care that you are thinking of, which will help improve the quality of life of patients. It doesn't have to be always, discovery science doesn't have to be a tablet or a drug always. Though mostly outside the palliative care setting, when they talk of discovery science, they're waiting for basic scientists to produce new molecules to be able to use for the benefit of patients. And after the discovery science is where we try out the new idea that we have, the innovation. And that is usually in the form of trying out the trials are what the ICMR will fund. And once the trials are done, it then becomes accepted practice and moves into guidelines. And typically, not so much in the field of palliative care, somebody has figured out that there is a 17-year gap when all these things have been done, but it's not being implemented actually in practice. So because I work in maternal and childcare and also non-communicable medicine, this 17-year gap actually makes sense to us. And for implementation science in palliative care, I was congratulate you because you're going to compress this gap so that as soon as guidelines are there, you're trying to implement it for the maximal benefit of the patients. And it's good to hear that two institutions are actually taking the lead, even though others I heard that there may be other premier institutions where this gap may still be persistent. Okay. And the same 4 Ds which ICMR has indicated, those of us who before ICMR came up with this 4 Ds, this is the hierarchy of evidence that we were all familiar with. Usually there is a simple studies which are all in the So the bottom three are what the ICMR is now calling as descriptive. So where we don't intervene, but I observe either through long-term cohort studies or retrospective case control study designs or cross-section study designs. And then, of course, there's a discovery of a new method of solving the problem which you've learned from the descriptive method. And then following trials, which can be as shown in green, you can have a non-randomized trial or randomized trial. And then, of course, it goes on into guidance. In implementation science, we are assuming that the entire left side is already sorted out. That means you're not going to do new trials or describe the problems all over again to start from the scratch. You now have a care package reasonably good, which you're all happy with, but now you want to make sure that all the patients who could potentially benefit from that are able to get them. But what's the gap? The gap is that guidelines are not uniformly followed, and therefore all the patients who should have got the benefit are not getting. So now we are taking a seat back to figure out why that is not happening. So that's the scope of the implementation science. And can we understand what the different barriers and facilitators are to see whether it can be done or not? And what are who's the primary beneficiary of all the efforts that we do? It's the patient. Okay? But in an implementation science project, we take one step backwards and say we want to set some outcome measures, not for the patient, because ultimately that's the aim, but who are the ones who are one step before that determines the outcome for the patient. So that's the key thing to remember in an implementation science project. So I'll just give an example of hypertension or diabetes control or common cancer screening. One is where I said earlier from trials and all other studies, the treatments is already known. So we call that evidence-based interventions. That part is already known. And the second part is where the implementation science project should actually start. We say that the intervention is available, but why is this intervention not reaching everybody who should benefit? And that is the initial part which you try to understand the body through the silver framework, which will help us understand what we call usually formative research. That means the research that is being done in the beginning, which should help us understand why the patients are not getting the benefits of the known intervention. And usually for us, we say community diagnosis and health system diagnosis. But because your project is largely in health facilities, you would probably restrict it for palliative care to the diagnosing what's wrong with our health system. Okay. So that will be the starting point for the implementation science project. And then once we have understood that, we then move on to figuring out how can we sort out those problems. So that those will be covered in a separate session called implementation strategies. Because we first want to understand what the barriers and facilitators are, and then accordingly come up with strategies to ensure that the patients benefit. And this is where you will see that the outcomes word is split into two parts. One is 4, numbered 4, the other one is 5. 5 is everything related to the patient. Here are all the patient outcomes. Even though we are interested in patient outcomes, in the project, we have to make sure that implementation outcomes is what we do. And if that is done well, the patients will get the benefit. So our entire effort in an implementation science project is not to start thinking directly for the patient. We think of who are the people who are the gatekeepers providing care, who may be helping or sometimes not so helpful. We have to work with those people in the hospital setting to ensure that the patients get the benefit. Two reasons. One is our own patients will benefit. Two, we learn from this entire exercise so that we can then abstract and say, if somebody else wants to do the same thing, I now have knowledge which we have learned from our experience. You should be doing the same. Okay. So it's translatable knowledge which you can then pass on to either new people joining my department in the hospital or to a different set of hospitals. That's why it's called implementation science sometimes or implementation research. Because I start with the question, say, what are the barriers which are preventing all my patients who should be getting the health outcomes or service outcomes, but who are not getting, and therefore I go through this sequence of trying to understand the viewpoints from all the stakeholders and then devising strategies which will involve all the stakeholders. And then figuring out how can I measure those implementation outcomes of the people who are before the patients. So health or service outcomes are for patients. Implementation outcomes, I must have indicators not for patient level. It must be at the ones who are providing the care. So it will be for the healthcare providers. So it can be for doctors, nurses, other allied health professionals. It can be at the level of individuals, health workers, or sometimes it can be above the level of individuals, which means in groups. So it can be for a department, it can be for a hospital, and so that's why the word health system is used. Even though the sample size calculation is still always done for the patient. Okay. So if I were to say that I want to improve by the end of the 3-year project, I want to improve care for patients, so whether they are getting palliative care and whether their business is all taken care of. I can say I want to set a target at baseline, I think it's 20%. By the end of 3 years, I want 80% of them who are eligible to have got the care and got a better quality. So the outcome is measured for the sample size calculation at the level of the patients. So then we can decide whether it's possible to do it in one hospital or whether we should get 2 hospitals so that we get sufficient numbers of patients on whom we can make the measurements. But the implementation outcomes are not on patient level. So I'll show you the photo of our project as an example for you to understand. We work with a lot of newborn babies, where for preterm babies, there is a treatment called kangaroo mother. Okay. Essentially hugging the baby. Okay. By the mother or any other care provider from the family for preterm babies. Who's the primary target? Ultimately, it's the baby. Okay. So that's why the first photo has only the photo of the mother and the baby. But for the mother and the baby to get the care that is intended, so that's the health outcome for the baby, neonatal survival, reduced number of infections. All that is all from the baby's viewpoint or mother's viewpoint. But who do I have to target? One step backwards. So then you see the next photo. I have to work with the health worker. So my implementation outcomes are targeted at the health worker. And the third photo is of a picture of the entire newborn care. So I must have some indicators to measure whether the environment, whether it's the physical environment or the social environment, the working environment there is all conducive for the baby to get the essential care that is required. So implementation outcomes are at the level of the individuals and at the level of the systems in which they are working. On the left side is all the usual health outcomes for the patient. It doesn't matter which field we work in, we use the same concept. So whether it's in pediatric care, whether it's in maternal care or palliative care, all the health outcomes will be thinking of our patients. And then we say the implementation outcomes are for the individuals who are working with the patients. So usually there are some words thrown around like this: acceptability, feasibility, adoption, implementation, maintenance. I'll try and explain what each one of them means. Are you all happy with the sequence? Sequences, implementation outcomes are measured, and for those outcomes, for the patient outcomes to occur, I must get my implementation outcomes sorted. And usually you will have in palliative care, I'm assuming that there is some care package, whether it's probably triggers, conversations, communication, and also maybe advanced care planning all of which you want to make sure that the patient gets the bundle of care. And therefore, the first thing I want to check is whether it's acceptable to the patient group who I'm working with, as well as before that, it must be acceptable to the healthcare workers. So we already talked, I heard today in the panel discussion, different viewpoints on whether sometimes, was it Sarah who said that may not be acceptable to some healthcare workers. Okay, so you want to make sure that your intervention package is acceptable. It's feasible to do on the part of the person who is providing the care, and then whether it will get adopted by the facility and run in the long term. Hopefully, only then we will get the health outcomes that we intend for the patients to get. Usually, health outcomes we can measure at two levels: individuals and the organization. So we must make sure that we are identifying indicators to see whether it's working. They should be at those two levels, and there's a guideline for that. So the first one is normally we say that we want to make sure that these two preliminary characteristics are taken care of. Acceptability is from the viewpoint of the person who I'm working with. So the doctors and the nurses should say, yes, your care package is acceptable for me. Feasibility is if I'm the person who's going and training, was it Dr. Pona who said that awareness levels itself may be very low amongst doctors, nurses, and not necessarily only the ICU. It may be problems in oncology, general medicine. So I want to make sure that whether can I deliver a class for so many groups or can I take sessions for several of them? Maybe in the first month I'll say I don't want to cover all of them. It's not feasible for me. I'll do only for the ICU stuff. In month 3, I will then increase the total number of target healthcare workers with whom I will work to a larger group. So I'll then scale it based on my feasibility. So those are the first two criteria to keep in mind. As an example, this is from our project where in pregnant women, they get eclampsia because of dehydration. And the treatment for that is the workers should give magnesium sulfate. And in the project that we work in, they are usually seen not at the large hospital, they are seen first at the peripheral hospitals, the primary health centers. And for the primary health centers, they do not want to give Maxim. Even though the protocol is printed and stuck in the labor room wall, they will not give it. Any idea why? Because for them, they're scared. Because it can cause side effects, respiratory depression. So they will not give that. So it's not acceptable to them at all. They just give, they say high BP, I'll give the tablet to reduce the BP. I will not give the magnesium sulfate to the woman who's got high blood. They are worried more about the consequences of the treatment rather than the complications of the treatments. So that's the problem that we run into. So we have to somehow figure out that how much can we actually expect them to change as soon as I start the project. Okay. Acceptable? No. Not feasible. Okay. There's no way I can do some interventions if there's a lot of resistance from the group that is supposed to be the beneficiaries for the ultimately for the benefit of patients. So they say it's partially acceptable, little acceptable, not acceptable, various grades. And some problems are at the level of the persons who are supposed to be the trainers for healthcare workers. We find that some things are not feasible initially or partly feasible. So we want to make sure that those are at the which stage you want to make sure these two are there. These two should be taken care of very early before I start measuring outcomes in the patients. Early on in the project, we must make sure that these two are taken care of. So there are some standard definitions for what outcome is and guidelines on when it should be used in a project. Second one is that the healthcare workers that we are working with. So the top is HCW, is the healthcare workers, and the bottom is for health facilities. And I said earlier that health are implementation outcomes we measure at the level of the individuals as well as the facility. So if I'm trying to get some staff members to provide kangaroo mother care for the newborn babies, I have to first ensure that they must start doing. It seems like a very simple intervention, but a lot of doctors and nurses don't know how to get started by helping the mother to have 60 minutes of kangaroo mother. So that's the first part. So I have to make sure that I can measure how many of them have started doing that. Once they start doing, you will then see whether I want to see whether they are doing it at good quality. So usually by the time I start doing things at scale, sometimes the quality gets affected. Or because I work not with the government, usually we set targets, they reach the target and then have towards all. So we want to make sure that not only get started, that means the care providers in the ICU or outside the ICU setting are started doing palliative care, but also are they doing it at a high quality? And then the third part is, if I withdraw my support, will they still continue to do it on there? So that's the third concept. Similarly, for the health facilities, we have the same sequence. I want to see whether this entire department has started doing it or this hospital has adopted the new care package. And then after that, how are they making sure that they can figure out that within all the departments that are involved, how are they allocating work or mechanisms to overcome conflict? How are they institutionalizing the new care package in palliative care? And then, of course, similarly, just like how I worry about will they do it towards the after the project period, same thing for the health facilities. So once we understand that there is a sequence, then it makes sense to adopt it. Okay. That is just to show that the entire unit or the department must all figure out how to make sure that it continues, not just adopt and then leave it after that without actually following through. And you might have heard of a framework which is used to measure how the entire process, both by the individuals and the entire organization, is doing it correctly. It's called V8 framework. Sorry, apologies for throwing too many words. Simple framework and now V8 framework. Simple framework to make sure that I have understood the determinants, I can get started. V8 framework is to make sure that I can measure over a period of time to see whether things are improved. So I want to evaluate, and therefore now I use V8 framework. Reach is all the doctors and nurses and other allied health professionals have I reached or have I saturated? So awareness was brought up as one of the key barriers. So once I understand from the formative research that not all of the persons who are involved in palliative care know all the nitty-gritties of palliative care, I then have to figure out how do I raise awareness to all the ones who are concerned? So reach, how will I measure? I will assume that it's very low in the beginning and I want to aim for a very high level of reaching all the persons who are going to be offering the value. So it may be 10%, 20%, 50% in the beginning, and I want to progressively increase that. I must have a mechanism to measure that at baseline and then at subsequent intervals to see whether it's progressively increasing to a very high level. I can't wait till the end of the project to reach a very, because reach should be one of the basic criteria. Soon after the project starts, I should be able to reach a high percentage of all the doctors who are taking care of all the nurses, psychologists, who are the other physiotherapists, who are the other staff who are going to be taking care of the patients. I want to then make sure whether they are doing it at good quality, whether they are effective. Dr. Guvara said you should feel comfortable. So I suppose that will come under that. I want to make sure that the ones who are offering that particular care are not only understood it and then don't get blocked because they don't feel comfortable. They should feel comfortable enough to be able to provide the care at high quality. For the healthcare workers, then of course slowly I hope that if I withdraw the project or the intensity of my intervention, will they still continue with the care that they will then go ahead and provide to the patients? So that can be started a little later. I won't expect maintenance or sustenance very early in the project or in the mid. Towards the end, I hope that once they all become little comfortable, they can then continue the project. After that, it's no more a problem. The project will withdraw or stop. The department should still be able to continue in a routine care.
Boy starts getting ready by himself. He picks up his jeans and wears them, then he puts on his jacket too. That he takes his bag, holds his father's hand, and walks away with him. When his father isn't threatened.
This is for the health facility or the department of the hospital. So how will I now measure? If I have 4 hospitals under me, I'll see 2 of the hospitals have adopted the new care package, which should reach all the patients. The care package, of course, it's already known from your previous trials what it should constitute. The modification that will be done is learning from the formative research in the beginning, which is a mix of the qualitative research and the quantitative research, to fine-tuning of the care package. So that is that's what I want to know, whether the hospitals have adopted the modified healthcare package, which should benefit the patients. And then, of course, after they have adopted it, how well are they actually following as per their own reports, or if as an outsider I go to that hospital, I can make it. That is called fidelity or implementation. So that's the I in the reading. Adoption, implementation, and the last one is of course maintenance. So with the understanding of the concepts of what goes into REA, I can now make it a quantitative measurement, but also quality. So what do I mean by that? I can have numerator and denominator and give percentages, but that's not enough. I must be able to also say, if my percentage is low, why is it in one hospital it's working, another hospital it's not? Or within the same hospital, I have reached 90% of the eligible doctors, but then they don't feel comfortable. Only 40% of them are feeling reached a comfort level on when they will co-opt palliative care in addition to routine intensive care. So I can now titrate my work according to my measurements from these indicators. So once the reach percentages have increased, I know that I've taught everyone. So now it's not a knowledge problem. There is more than knowledge, something to do with motivations, their beliefs, their attitudes. So maybe I now need to work on a different set of determinants. It's not the knowledge which is the, whereas maybe initially knowledge may have been the barrier. I therefore did my focusing of ensuring that knowledge was what was imparted. So the re-aim framework I now modified slightly to say R, E, and M I can measure for the individuals, whether I reach 100% of my doctors, nurses, whether they are now doing it at a good quality level and whether they will maintain. Whereas for the health facility, or I can look at it as a department or a hospital, or if there are multiple units, I can then measure and say how well is the health system adopted the package, how are they running with it, are they doing it at good quality level, and if it's functioning well, can no outside support is required, whether they will do it on their own, because they have institutionalized it to suit the requirements of the hospital. So to summarize the implementation outcomes, they are different from service outcomes, even though that's what is ultimately our aim, the benefits to the patients that we're interested in. But we set up our work to make sure that we can focus on the ones who are determining the care that is provided to the patients. Is that okay? Implementation outcomes are clearer. Well, we are going to move forward. I have a short session on implementation study phases, because this is being done as a project mode. Usually we split the projects. If there was no implementation science project, I would have taken this class. But because you're working in a project mode, let's say it's 3 years, then we want to make sure that we allot some time and call it study phases, so that we work in some sense of how to do some things at the beginning, and then to do some things towards the middle, and then plan for what is it that we're aiming for towards the end, and what kind of teams should I have. So one of the sequences that we follow, and Dr. Bhavna may have a slightly different sequence, or it's pretty much similar. So we have some understanding in the. So this requires me to change my hat from saying I know everything about mental and child health. I put on a different hat and say, sorry, but I don't know some things, and therefore I must talk to all the stakeholders. And remember, I told you from non-palliative care background, and that's why listening to the panel discussion, I figured out so much. I didn't know there was no the definition of palliative care doesn't have anything to do with death and end of life. So, like that, if you talk to a group of people who are already working, they were very good critical insights provided by the doctors and the nurses. The nurses said that we are not part of your conversation with the patient, you shoot us. So that's something that might come up in your formative research, very early on. Sarah said that talk to the staff and the patients and find out what they think about life and death. So some basic or existential questions would all need to be answered. There were other points brought up about what's the religious background or the spiritual meaning for life and death. So all of those things will have to get covered in the initial part where we say that we are going to do formative research. We set aside some time for that in terms of few months in the beginning. And then we do what is called the co-design of the package. So which you will see is slightly different from how we work routinely in a hospital setting. In a hospital setting, there's a clear hierarchy. We figure out, I tell you some things, you all do the rest of the work. This is how science moves forward and healthcare moves forward. In co-design, we normally include several of the stakeholders because we've got opinions from them earlier on, but also the care package also they have us. So which means that patients, family members, administrators, hospital administrators, all the caregivers in the ICU, caregivers from the palliative care department, all of them may actually be sitting to decide how will we get this done. We've heard that what are the barriers from different departments. When we talk to them, they tell different things. Some things they'll say on stage, But when you talk to them personally, they'll say a different set of things. For us in community medicine, I have to go sometimes to the coffee shop because the fellow tells me in the meeting hall, tells me a different thing when he's having a chai outside. So we have to get to the truth of what actually they mean when they say different things. And then we design this package, and then I implement it. And I also, at the same word, add another word called iterative implementation, which means I try it out and then give myself and all the other team members time to accept that some things that we tried worked out, some things didn't work out, let's change. So that we have multiple cycles of learning, maybe every 3 months or 4 months. We'll all sit together and decide that we thought that this was a good idea. Giving knowledge to everyone will improve care. And then we realize, no, they've all reached 90% in all the post-tests. They have not changed any of their practices. So maybe we have to do something else. So like that, we go through a few set of cycles of implementation and only then move towards the end stage of figuring out whether all our patients have benefited from baseline where we said we're not happy with what we were at baseline. Is it increased to a good, comfortable level at the end? A Gantt chart will look something like initially research which is descriptive in nature to understand why some things are working well. Good to contrast with another hospital where things are not working well and you're already at a level where you're a little advanced. And then even within our own hospital, then we say, even though we are pretty good, we still are not happy with where we are. We think it's work in progress. We can still improve even further. And accordingly, I must make sure that my project team members, I get the correct set of people to do the different. So you can see that in the beginning, I want to understand what the barriers to potentially high quality palliative care are, which means who should I talk with? Is questionnaire a good method? Yes. So you want to make sure that all of the conversations that I'm having at the beginning are predominantly qualitative research rather than quantitative. And qualitative research mindset is different. The people who are good at doing that are different. Therefore, I must make sure that on my team, I have people with qualitative research experience. In addition to counting what number of doctors have attended the class, what their tests are, what's the pre-post scores of the nurses are, that is quantity. But if they don't attend my class at all and I organize a class, I then want to talk to them why they're not even first attending the class. Or if they're attending the class, they tell me later outside, I don't believe in all this. I want to understand why they think like that. So that's the qualitative research part. Completely different skill sets. I must have those two kinds of people on my team. The second one, after we made the code design, which of course is where all the stakeholders are all involved, we design the package, and then I want to roll it out. By that time, I must have slightly different teams. So I call that implementation support team. That means the ones who are going to figure out how between palliative care and intensive care or maybe other departments, what does the guidelines say, what's the protocol say, how to make sure that the protocol is taught to everyone. That's the clinicians and others on the healthcare team who are happy to provide the lectures and help others follow through the different protocols or regimens. The second part is slightly different people from within our healthcare professional team who are also little research oriented. So they are the ones who are going to try out something and find some problems and come back and say, I want to have an in-depth interview with those two people who are not doing the things that I want to arrange a focus group discussion and figure out quickly why some things are not moving forward. Even though everybody agreed in the co-design phase, in the formative research, this is what we got. But when we try it out, it's not working. So I want to be able to do, in addition to my clinical work, I want to do some research. In parallel, I have a research team who will do all the measurements. They will calculate all the reach, conducted the sessions, they will tabulate the scores, come back and tell me what percentage are attended, what percentage didn't attend, are they feeling comfortable enough to take the classes, can they pass on the message to others, can they convince others to do at high quality. So I may have some metrics to make sure that all of those are being done, and I need a team to collect that input. Okay. That's the research team. Occasionally, because implementation science is little new, I may have an external who are not part of our hospital at all. I can get an expert from a different setting to help us get started. That's it. Or we get covered during our practical. I've put co-design here because we do all the initial understanding of barriers and facilitators. And for ease of understanding, I've put it as a single standalone event. Usually the word used now is actually co-production more than co-design, which means that at one point in time, we talk to the nurses, we take the feedback from the nurses, and then we say that counsel should be done with the nurses. So that's we've taken care of one set of how we want to design the delivery of the care package starting itself. And then after some time, during the iterative cycle, I may again do this once. Because I now come up with a new set of problems, which requires maybe I need to talk to oncology department. It's not enough for us to talk to all the palliative care and the intensive care. I first need to talk to the palliative, to the oncologists or general medicines. So I keep fine-tuning my approach by talking to the stakeholders as much as possible. Some things in the beginning, but always when we do, we always find new values.